This conference will now be recorded.
Okay, you guys are good to go.
All right, I will start. I don't know how many people are there, but I will just say good evening to everyone. And thanks, Dana. Thanks, Paige, and the CDF team. I really like this kind of platform to get the people aware about different topics. So this is a good initiative by you. Congratulations on your baby.
Thank you.
And we look forward to work with you more. And those who are right now attending this live webinar, thank you for taking your time from your busy life and during this kind of a crazy situation. So thank you. So Paige come up with this idea that we should be talking on insulin affordability and available option. And then I realized that this is the prime time to talk about that. The patients that I'm seeing right now through telemedicine, 90% of our work is now remote. 1 out of 3 or 4 patients are being furloughed right now. So I totally understand that this is so important for people to understand what are their options, what they can do to afford insulin. Insulin is life-saving. There is nothing that you should go away from insulin. So we'll be finishing our presentation in about 15 minutes to 20 minutes. And Dr. Khan is joining with me. Dr. Akhtar. And he will be giving more details about some scientific stuff, and I'll be just taking 5 minutes of your time in setting up stage. And then we will have about 20 minutes of question and answer session at the very end, and happy to take any questions you have. And even in the beginning of the sessions, we were discussing together that if you have a questions not just related to this topic, but something else, feel free to throw in the questions and we'll be happy to help. All right, next page. So I know that everyone living with type 1 diabetes has seen this picture. If you have not, okay, this is Benting and Best. They discovered insulin in 1921. And why I brought up this picture, it's very important. By the way, there is like $1 million question. Is there any chat feature here? What's the name of the dog here? Does anyone know? There you go, somebody is writing. Yeah, Marjorie.
I got it.
So it's like a very historical, picture and historical importance of this dog, because that is associated with discovery of insulin. And why I brought up this picture, because Banting and Best, when they discovered this, got Nobel Prize, of course, but they sold this patent at only $1 to the University of Toronto. Just imagine that, right? You have a patent. This is something that is kind of like can make you billions of dollars, but they just sold it for $1. The idea behind that is that the insulin should be available and accessible and affordable to everyone. That was the idea, right? And then look at now, next, is that the insulin is one of the costliest life-saving medication. And the insulin cost in last 3 decades, so I'm talking about from 1990s to right now, has increased by 1,000%. You won't believe me, okay? But you can read more scientific articles. The insulin cost is soaring high in this country. Next, and there are multiple consequences to that I'm going to talk about that in a minute. But this is just, I Googled through a GoodRx. In case if you guys don't know that, the GoodRx is a website that gives you a cost of a medication at different pharmacy. So again, let's say, for example, you search a Humalog into the GoodRx, it's quite possible that the one pharmacy is giving you at $160 and another pharmacy is giving you at $400. So between pharmacy, the cost is very different. And I just selected the lowest price that was available on the GoodRx. And you can see here, I don't have a cursor to show you, but the cost is ranging anywhere between $160 to about $600. And more newer insulin, which are really good insulins, don't take me wrong, but they cost you a lot more money. Compared to that, if you think about the older insulins, and again, Dr. Akhtar is going to go into detail about those older and newer insulins, so I will not give you much detail right now. But human insulins, they cost you anywhere between $20, $25 to about $180. And $25 is like kind of nowadays, very popular so-called Walmart insulin. Next, please. And this topic, of the insulin cost has been debated, discussed on a multiple scientific forum, on a lay press, media. And the one thing I really like about the type 1 people living with type 1 diabetes is that it's a small community, but they are very vocal. They speak loudly, and I think that's what we need. Think about the other diseases that they are rare. People don't speak up, and then you don't know much about those diseases. The general public, the Congress, the Senates, they don't have awareness about those kind of rare diseases. So keep it up, guys. Good job. So you guys made a loud noise. It was heard by multiple people. Of course, the Congress people needs to hear from all of us. And a lot of articles being published about that the people are rationalizing their insulin. In a studies that they say that 20 to 30% of people with type 1, I'm not talking about type 2, type 1, they are rationing their insulin. So let's say you are taking 50, you need 50 units of insulin, but you are trying to save some insulin for reducing the cost. So you, rather than 50 units, you would be taking only 40 or 45. That's not good. That's on a country which is spending billions of dollars, or I would say one of the highest spending on healthcare, and still the country is not doing that well in terms of the accessibility or affordability of this life-saving drug. Next, please. So at the time of this kind of an insulin price, a lot of people were talking about the Walmart insulin. And just to give you a really truth on this one, or reality, that this is not a Walmart brand, okay? There is a contract between the Walmart and the Novo Nordisk. So this human insulin is still manufactured by the Novo Nordisk, but now sold and probably marketed by Walmart. And they call it their own, like a Relion, Humulin N, R, and other names that Dr. Akhtar will go over that. Is it true? The answer is yes, it is true that it's available at the Walmart at $25. Next, please. And a lot of people have wrote about the good thing and bad thing about that. This is a really good article. It says FDA review, but don't think that this is an FDA website. This is an independent entity. It's not the FDA. So take that with a pinch of salt. But they just gave a really good idea about, what is this insulin, how that can help you. And some people definitely say that, oh, that is a lifesaver for them. Understand? Next, please. The other way around, there are also discussion about that people have died taking this kind of a Walmart insulin or human insulin. And it's a debate now that it's a good insulin, it's a cheaper insulin, but then other way around, that's a dangerous too. So if you don't know how to take it, or if you are not a best candidate for this insulin, this is not for you. So it can be very dangerous. So far, most of the states are allowing you to get that $25 Walmart insulin without prescription, with the exception of Illinois. And that's where this case happened. And so they decided not to have the insulin available without prescription. So to my knowledge, that's the only state where you cannot get insulin without prescription. Next, please. So I just gave you some background on the insulin cost, how much it costs to all of us. Despite that this is a life-saving, I feel like it should be free to all of us. But anyway, now the next session, we're gonna switch the gear, and Dr. Akhtar is gonna speak more about the science behind different insulin and giving you some idea about whether this Walmart insulin or human insulin is the right option for you. Dr. Akhtar, you can take over from here.
Thank you, Viral. So we can have a look at the next slide. So I will basically summarize the physiology of all available insulins, and from the old-fashioned, the NPH and insulin R, and the new rapid insulin analogs and the long-acting insulin analogs, and how are they different and how should we use it properly. And if you can see here that that's the graph, the lower one is that y-x is the, you see the time, and xy is the how and when they make a peak. And if you see that the rapid insulin analogs like insulin listro, aspart, glulisin, like the Humalog, Novolog, and Apidra, and very similarly the Fiasp will be very similar, or the upcoming, the faster Humalog would be very similar too. So they make their onset is earlier. You can see, compare the insulin regular, which the Dr. Shah was talking about, a cheaper and older version of our shorter acting insulin, which is the insulin R, insulin regular. It's, if you compare that to the graph there, then one of them is the rapid insulin analogs on the left side, and it makes a peak earlier, the onset in action, and also the peak and is earlier than insulin regular. And the duration is also different, as you can see that insulin regular is a little longer than the rapid insulin analogs. And you should, consider these things when you are using this all the physiology under the observation of your physician, and because they are not exactly the same insulin, it works in a very different way. So it affects your timing of your meal time, and if you will be exercising, and how much you will be eating, how much carb you will be consuming. So it's really time to change the things if you really want to do that, and you should discuss with your physician. Same thing with if you look at the long-acting and actually intermediate-acting insulin, we call insulin NPH, which is insulin N, versus long-acting insulins, insulin detemir, which is Devemir, insulin glargine, which is Lantus, Basaglar, and also Toujeo, insulin glargine. And also, it's not here, but more, longer-acting, ultra-long-acting insulins. It's the 300 concentration insulin glargine, or versus Tresiba and insulin degludec. You can put it into this category here. Compare the NPH, and you can see that NPH also makes a peak. And versus the other insulins, the other basal insulins doesn't make a peak by definition, and detemir is actually can make a small one, but the other insulins don't. So the advantage of these insulins are they take some time to be effective, but they are in our system is in a longer time, and then it's not like NPH is not covering the all 24 hours, as you can see. And that's why we most of the time use more than once the NPH in our patients, versus in the other insulins in the longer actings we are using most of the time once a day. And the main differences between NPH and the longer acting insulins are the duration of time and it making a peak effect. So why it matters is because when you use an NPH, and let's say that you take in the morning, and let's say that you take at night, and when you take at night, it can make a peak when you are sleeping. That's something should be considered when switching, and or discuss with your doctor based on your lifestyle and what time you eat dinner and what are you doing that time. And it also may increase the hypoglycemia risk for the overnight NPH insulin compared to other long-acting insulins. So that's one of the main problems with using the NPH and the making the peak action. And also, these insulins are the old-fashioned insulins are only in vials, and the regular insulin cannot be used in the pump. And there are these are the main differences, because when we do this, the pumps, when we try in the pumps, also in the smart pumps, you'll see that these all algorithms have been tried in the Lispro, Aspart, and they are not being tested in the regular insulin because its physiology is very different. So we cannot expect the same result will happen. So that's one of the main issues that also we can encounter if we use this in a pump. So we don't recommend that. And you see that insulin detamide also is one of the first long-acting analogs, and it's not it fully covers the 24-hour. Most of the time we use twice a day in type 1 patients. In other insulins, depends on the type and duration, we can use probably once a day. And this is just a summary of how the insulin physiology is different, and timing of exercise and timing of diet should be considered. So we can have a look at the next one. So comparing the human insulin and the rapid insulin analogs and the other analogs, if you compare the rapid insulin analogs versus the insulin R, if you compare the insulin NPH versus the longer analogs, then you see that the others are obviously inexpensive, and there's a huge price difference, as Dr. Shah mentioned. And there's an easier access, doesn't require any prescriptions. These are all advantage for the patients are struggling financially. But also the cons are doesn't resemble the natural insulin in terms of action, that how you used to it. So the rapid insulin analogs in onset starts in 5 to 15 minutes, and you are used to starting that. On the other hand, the insulin R needs to be taken 30 to 40 minutes before meals to be effective. And the variable absorptions in patients also another problem, especially with the insulin NPH, is the increased risk for hypoglycemia is also another problem, especially for the night hypoglycemia. Also insulin R, for the timing is very important when you take, is also slight increased risk of hypoglycemia. And insulin R cannot be used in the pump or in the other smart pumps, in the hybrid closed loop pumps. They have not been tested, and they are only available as the vials, as an NPH and the insulin R. So if you want to consider to use this different type of insulin, it's always an option, but it needs to be discussed in detail with your physician. And so your diet, your exercise habits, and your working schedule, are you working in day shift or night shift, or other factors should be all considered, and it should be followed probably with a continuous glucose monitoring. I would suggest you to monitor that to get the perfect dose for you to work it for your body. And Dr. Shah, do you want to add anything else?
No, Dr. Akhtar, but can you go back to one slide, please, Paige? Can you discuss a little bit more, Dr. Akhtar, about like when we talk about Walmart insulin? Is it regular and NPH both? It's a different, and what are those 3070 insulins, which are not in this graph? So yeah, it would be better just to discuss. Yeah.
Yes, good question. So the regular insulin that basically when we are referring to as a Walmart insulin, basically most people are referring to as the insulin R, which is the regular insulin you can use for as a rapid acting insulin. Also, you can use this insulin NPH. Also, this is also available as an old-fashioned insulin. You can get that. The 70-30 insulins are mixed insulins. There are also 75-25 insulins in other countries too. In United States, 70-30 is available. So 70-30 insulin is basically 70% NPH and 30% is regular insulin. So it's comes with a fixed amount. So whatever you are giving is percentage-wise, you are taking 70% of NPH and 30% is regular. So most of the time, it can be a good fit for the type 2 patients that they don't want to take too many injections. Also, there are some they can make with the analogs insulins too, and then the mixed insulins. But for type 1 diabetes, it's a little bit tricky because when you increase the dose, you are increasing the both of them. When you decrease the dose, you are decreasing the both of them. So it's kind of that you are not eating exactly the same thing. And also when you increase that, like you are also increasing your NPH insulin too. So even if you take them twice a day, then it's also kind of increases the regular and the NPH at the same time. So it's very hard to manage the things in this way. Even if you make a carb counting in that way, let's say that you cannot say that I don't want this NPH too much. I'm having the overnight loss, but on the other hand, I need my regular a little bit in the mixed insulin. It's a little bit tricky to make adjustments in type 1 diabetes for the mixed insulins.
Right. Okay. Great. Thanks.
And also insulin degludec, which is Tresiba, is not on this graph, and insulin degludec effect is over 40 hours. So, and it doesn't make a peak also, and then it's the one of the longest acting insulins that we are using.
All right, great. And this is again, we wanted to keep this presentation as like very brief, because I think a lot of people know about the insulin. You guys know a lot about how to deal with type 1 diabetes and the insulin, probably better than us. But we'll be happy to take the questions. I think that's the main idea behind having this kind of a webinar or series, is to have a more interactive session and having a more question and answer.
Yeah, so I have one really fast kind of get us started.
Okay, sure.
Do you know what kind of insulin affordability programs are out there for those with type 1 that could be needing help during these times?
Sure. Do you want me to take this question, Dr. Akhtar, or do you want to?
Yeah, whichever, however you want.
Okay, sure. So during this situation, the COVID situation, all the companies have realized that it is going to be a financial problem for a lot of people with type 1 diabetes and type 2 diabetes. So a lot of companies are offering their program. Again, each one has their different terms and condition. So for example, Eli Lilly, that makes Humalog, which is an insulin lispro, offers for a certain group of people, again, those who do not have a job currently and you need to meet those financial criterias, at about $30 to $35 per month prescription. Similar program is also by the Novo Nordisk. So Novo Nordisk is the manufacturer for Novolog that a lot of people are using. That's a rapid-acting insulin. And they also manufacture long-acting insulin that is called as Tresiba. That's a longer one, or Levemir. So they also have a similar program. So best thing during this situation, if you have any question about, which companies are offering what kind of a program, just Google about that company. Every company right now, the website has the COVID, or financial related FAQs and questions. Click on those parts. They will offer you some programs, the coupons. It's very easy. Just Google it, search it, and you will find it. So I just gave you an example about the Lilly and Novo Nordisk, but that's true for all companies, even companies, those who are manufacturing glucagon. That includes the newer glucagon, like a nasal glucagon. So they are offering first 2 free prescription with the coupon. And there is another one called as GWalk, G as in George Walk. That is a liquid stable glucagon. So you remember, like, how glucagon has to mix with like water, and there is a white powder. This one is already pre-mixed. You don't have to do anything, just take that. And that they are offering also free right now, first 2 prescriptions during this situation. Take that advantage. So if you're not aware, go to their website, download those coupons, call your doctor to get the prescription. Dana has a question.
Dog is freaking out at the thunder, so I apologize for barking in between. Hunter,
That's okay.
my question is, I'm so sorry. This is my life. My question is, do you guys endorse? So I want us to be able to put stuff on our website or on social media, and of course I would always, Hunter, check with you guys first. Are you okay, or can you give Paige a list of something that we can add on that's sort of BDC approved, so that because I never want to put anything up that is not. I'm sorry. I'll just show you the craziness of him. He is insanity, Hunter. But I just want us to be able, whatever. I want you to endorse. So if you could give Paige whatever you guys, agree to at BDC, so we can offer that option, Hunter, to our patients and to whoever might follow us. Sorry, that's what I'm trying to get out in a very bad way. So sorry. I'll mute myself.
It's okay. So if I understand the question correctly, then you asked us that whether do you endorse this human insulin or not, in a simple one-line question.
No, I'm asking, so you talked to Paige about Googling different things to find coupons and stuff. I want to make sure whatever we're telling patients or people to go, if they're going to go access somewhere, I want to make sure when we tell them something like that, that's something that you and the BDC, are comfortable with people Googling and trying to find that if they need to.
Definitely, definitely. And I feel like, being a patient, not just with type 1 diabetes, but anything, you have to take that kind of a torch on you, right? So it's like, do everything that helps you, and feel free to, reach out to us if you have questions about, like a lot of people, they fill out those forms and then they don't get any response from the company, but they don't know how to contact, who to contact, right? Feel free to, if you are a BDC patient, that's what we do. We have a wonderful social worker, Lisa Meyer. That's what she does, like, calling all these different companies, trying to figure out how we can help our patients to find financially, viable or affordable insulin prescriptions. But yes, Dana, definitely Google it. And Paige, remind us that I think we wrote an article that you are planning to publish along with this, right?
Yes.
And we have a link to all these kind of like different companies where you can just go, click on those links and find out about the programs.
Yeah, so we have a digital news notes. Our summer edition is coming out, I want to say beginning of June. And it'll have your guys' article in it. It goes over all the information in this presentation, as well as expanding on a few resources for affordability. There's a couple of paragraphs in there about that as well. So if you want to get that emailed to you, you can either send me an email or sign up on our CDF website. There's a news notes button. You just click on it, fill out the form, super easy. We can send that to all of you if you're interested as well. And then someone had a question too, just to repeat the name of the stable glucagon to make sure we have it right.
That's a GVOKE, G as in George. There is a hyphen and then VOKE. And I think Beth already replied that in a chat box, so somebody can look into the chat box and look at the spell. Yeah.
But I have a question.
Yeah, sure. Go ahead.
With the GVOKE, the prescription for like the special they're running right now. Oh, hold on. I have a child with a bloody nose. I'm sorry. I'm gonna ask in a minute.
Meanwhile, we can take questions from other people.
Let me see here.
Please ask us questions. Otherwise, I just feel like we didn't do a good job.
Or you answered everything just so thoroughly. Everyone knows exactly what you're talking about.
I agree with Paige. You guys did such a thorough job. Although you didn't mention, I'm archaic and I'm on Lantus split because it works for me, because on everything else I'm not on a pump. I know I'm weird and I like bottles. I don't like pens. I find regular insulin, you lose like 2 to 3 units with the pen if you're just injecting versus when you do it with the needle and a bottle. But with the Lantus, but otherwise all the new insulins kept me at like 30. I actually could take no regular on them. So, sorry. So does anybody do Lantus anymore? Am I like the last of the Mohicans? I'm the last person.
No, a lot of people.
Twice a day?
Yeah.
Yeah.
Is the question is and other people are taking twice a day?
No,
Yeah,
I
that's the
guess the
question.
question is, everybody says it's interesting because everybody says it's, not as effective, but it's really effective for me. And so how many times do you have patients that you're trying to fit into sort of what the newest program is, which is awesome, but maybe that's not necessarily what is best for them? And does their insurance companies then dictate, because I'm lucky enough to be able to sort of do what I want with that, but dictate what the insulins that aren't good for them? And I know that's part of what this conversation is about, is not being able to get the insulin that's actually best for you through your insurance.
Right, right. So I totally agree with you, Dana. And the first of all, I would say nothing is weird when you manage your diabetes. Diabetes itself is so weird that we don't understand what are the reasons why people do develop type 1 diabetes. It's weird that we don't have so-called the treatment that simulates the pancreatic insulin secretion, right? So every single of us treats the diabetes in a different way. So again, I feel like there is nothing weird. Whatever you are doing in managing your type 1 diabetes, that's your own strategy.
How difficult, sorry, and then Beth, I'll let you do yours. How difficult is it though with certain people in getting there, if it's not what the norm is or what, is sort of the trend? How difficult is it for patients to get the insulin that they feel is best for them at the time? I know this is a little off subject, but.
This is a great question, and we do see patients, like for example, I will just give you an example. Some patients would say the Humalog works best for me. Other way around, some people would say Novolog works best for me, right? I'm not denying that fact. Now on the book, on a science, we talk about the mean. Now in a statistically mean, meaning by that, we have thousands of people in a study. We pull all the data together. So when we analyze the data in a science, we talk about the average. That's the mean. It does not represent the individual. So that's why a lot of people say, this insulin works best for me, whether it's Lantus or Humalog or Novolog or Tresiba. We do believe that. Problem is that the insurance company dictates that what insulin that you should be on. For example, each company goes through, some companies are 6 months, some are 1 year. They have a contract with either Eli Lilly or a Novo Nordisk. And then they will tell you that, okay, you are on a United Healthcare plan. You are only eligible to get the Humalog, not the Novolog, because for them it's a cost saving. And the reason that they will show you is the textbook. They will say that the Humalog is not different than from a Novolog, right? I get it, but it's really hard. It's really frustrating. I don't have a really clear answer to that question, Dana, but we do come across a lot of people that they feel like this insulin is the best for me, but we do not have a best way to get that best insulin, So in that situation, what we do, we try to come up with a strategy that can work with that alternative insulin that is available through that insurance company. Sometimes it works, sometimes it may not work. We try to fight with the insurance company a lot. A lot of people have questions, and probably they don't know that how much time that we spent about fighting with insurance companies. In just a brief, because we have a time. Let's say if insurance denies particular insulin,
We actually have
they
you cutting out
text
for
the
some reason.
doctor that we are denying
Real bad. We're real bad.
with reason A, B, C, D. Now,
Yeah, Viral, your voice is kind of
sometimes A,
cutting. Is it the
B,
audio?
C, D are easy enough to write back and say that this is a wrong perception or wrong information.
I'm gonna give him a second. Hopefully he sees that I muted him because it's coming across awful for me.
So, can you hear me? Can you hear me?
Yes.
Okay, I can kind of answer. You know, I know what he's trying to say.
Nope, it's not working.
Your voice is kind of gone. So basically, you know, we
your
do
network
the
is
prior
strong, then you can
authorization
probably
for the.
explain this process of like, the prior authorization.
Yes,
And
I
it's,
am.
it's
That's
really
okay.
a difficult
So,
process.
So the problem is that, you know, they keep changing that also. You know, we get a letter, let's say that patient is using Humalog, and then 6 months later it turns to Novolog, and patient already has paid for that, and then there is another paperwork doing that things, and it's also changing the things from A to B, B to A all the time. And also same thing for long-acting insulins too. You know, Lantus, Basaglar, Levemir, Tresiba, 2JO. So, and we cannot even keep up which one is going to be paid, which one anymore. So our educators are really good in terms of helping us, our social workers and, you know, diabetes educators. And sometimes we, you know, kind of argue that, you know, because this patient is having overnight lows, this, that, we can also put some science and behind it that in terms of comparing the ultra long-acting insulin versus a relatively speaking short-acting long-acting insulin. And then it's kind of Lantus to Tresiba versus, you know, Levemir to Tresiba or vice versa. But we're not very lucky, even though we do for the rapid-acting analogs, unfortunately. So the insurance companies are more amended that, no, they are working in the same way and other things. And also there are some people says that, you know, I like this Humalog, for example, but it doesn't work with my long-acting insulin. But when I change to a different long-acting, they work very well too. So there are so many things we also learn from our patients too. So we are not like underestimating what they say. Especially, you know, me, I always kind of make a note that if so many people are talking about these things, because we are not exactly the same. And some of the long-acting insulins like Tresiba also work in a very different way. So there is an albumin binding versus others don't. So, and if there is any problem with the rare diseases, albumin issues, and other receptor binding problems, there will be difficulties in using other insulins too. And there are so many other things that we also don't know yet for why Humalog is working for some people versus Novolog is not working. As Viral said, that we use this in the studies, thousands of patients, so 1 or 2 or 5 or 10 patients doesn't mean anything in a study-wise speaking. So that's the problem. Otherwise, they are also our patients, they are also real, but then they are bringing us that, you know, 95% of the patients was fine. So then there is no point of listening to these people, but I think we should respect everyone's choices, and I hope that one day they will be similar prices and the insurance companies will give us more options so we can just choose among them whichever we want based on the whatever patient wants. Like the same thing for insulin pumps. Maybe that's not the question, but same thing is some insurance companies mandate you have to use this, or you can only use this, but you cannot use this. So I think that's also wrong, that the patient is living with that 24/7, and patient needs to be very comfortable what he or she wants to use.
Perfect. And then Beth, I know had a question, but I don't know where she went. Let me see here.
There is a question, new insulin that is fast acting. I don't understand that one. Is what is new?
Yeah, that was Pat's question. Pat, if you want, your mic is on, you can ask your question. Maybe not.
I'm sorry if you're talking to me. I didn't hear what you said.
You're fine. Did you have a question for the docs at all?
Yeah, that I can't think of the name of it. It starts with an F, but it's the fast-acting insulin, and I just
hear
pros
me?
and cons about it.
FIASP.
Yes.
Yeah.
So yeah. So what's the question about FIASP? Is a general question about what is FIASP and
I've heard
about it,
pros
or is
and
there a specific
cons.
question about it?
Can you guys
I've
hear me
heard that-
now?
Sure, sure.
I've heard that it really works well, and I've heard that it doesn't work well.
So, I mean, FIASP is the faster Novolog, basically, from the same company, Novo Nordisk. So what they did, actually, they got exactly the same structure of Novolog, then they attached two other molecules and to increase its absorption. So the same thing that there is another insulin is coming up with the Eli Lilly, which will be exactly the same homolog and attached with a substance which is called prostaglandin to increase the absorption. So we don't know the name yet. I'm not sure if it's coming in this year because of coronavirus or not, but we have available FIASP. So FIASP is, I got like a different feedbacks from patients. So some patients says yes, a little, works for them, and some patients that it's not a huge difference. Also, the coverage is very different from insurance company to company. So basically, FIASP is supposed to be that absorbed a little quicker Novolog. Basically, they attach the biotin, and there is another molecule that there is another amino acid that increases the absorption. And then it's a little faster. And if you do in the separate studies head-to-head with Novolog, and it's a little faster. But if you look at the longitudinal data and for the making as a pool of this, all studies are done. So they are still faster, but it's not like a huge difference you can see. And the difference is not more than 5 to 10 minutes. So even though the label is broad and it says that you can take it just before or just after or a little before the meals, we would suggest that you should still take a little early than meals like the other insulins. And then if your insurance is paying, you can try. And compared to Novolog and Humalog, the same thing in the study, the faster Humalog, again, I don't have a name for that, also for FIASP, which is faster Novolog. There are more infusion site problems and more injection site problems because there are more different substances you have been exposed, and they are causing vasodilatation and causes more redness, itchiness, and other things in some patients. So these are the pros and cons you can see. Is a little faster, yes, but in some patients it's not that fast. And on the other hand, in some patients, not very often, but it may also cause some infusion site or the injection site issues.
Okay.
Perfect. And then I know Beth had her question.
So I know that the Gvoke comes in like a pediatric size and an adult size. Does the nasal glucagon come in a pediatric dose and an adult dose as well?
Great question. Can you guys hear me now or no?
Yes.
Perfect.
Okay, all right. And I will take that question because I did
Sure.
glucagon studies. So nasal doesn't come with those two different doses because they tried only one in both and it works exactly the same. And why? One of the reason is that it highly depends on the technique. So let's say if you are not doing it very well, and that happens more in a kid, then you get a less response, right? So they wanted to have a slightly higher dose for the kids, and it works. So that's why it's only one. Versus Gvoke is the intramuscular or subcutaneous. So once you take that injection, it's 100% in, less chances of error. The other thing is that it's off the topic, but I just would like to mention a lot of, since you asked about the glucagon, we did studies and we showed that even if you take 1/10 of the glucagon dose, it works very well. So we are using 1 milligram right now, but let's say you have a half a pen, which is 0.5. That's a pediatric dose, you want to call it, but trust me that it's going to work equivalent as a 1 milligram. And we used actually in one of our study, we called as a mini dose glucagon study. We used only 150 microgram and still it was working really good as like 1 milligram.
On that as well, so with the Gvoke, I've heard of diabetics using it as kind of like a low treatment in a way, so them using many doses of glucagon to treat lows. Are you able to constantly pull from that ready glucagon to treat lows, or is it a single-use only glucagon for that injection?
That's a great question, and that's why we did that mini dose glucagon study. That's for prevention of hypoglycemia, not to treat the hypoglycemia. There is a difference in prevention versus treatment, right? So for that, we need some kind of a stable glucagon. Gvoke is stable glucagon, and something that is readily available in a pen form where you can dial it up and take dose that you want, right? So the Xeris Pharmaceutical, by the way, if you know that, it was a Colorado company. Now they moved to the Austin. They are planning to come with the multi-dose a pen, like an insulin pen, where you can dial up and take that 100 microgram or 150 microgram dose as needed for a prevention of hypoglycemia, not for treatment of hypoglycemia. Remember that part. And this is really important when you are sick. So for example, let's say, and this is true in kids, and kids they have done a lot of studies around that part. When kids get sick, they don't eat. Okay, they you know, it's hard to sometimes make them understand, of course, right? And so during those situations, this kind of a rescue, so initially they call it a rescue glucagon. We call them a mini dose glucagon afterwards, but those kind of like a small dose really helps during those situations. That will keep you away from the hypoglycemia. Yeah.
Gotcha. Okay. If anyone else has a question, you're welcome to type it into the box.
And I'm so sorry for some technical difficulties on my end. That's the technologies. This is how it happens, right?
It's our new situation. So, okay. Well, if no one else has any questions, I want to thank both of you so much for doing this talk. If you want to see it, it'll be live tomorrow on the CDF social media sites, and as well as news notes. If you want to get news notes and get that emailed to you, please do. You can sign up on our CDF Facebook page, or you can just email me and I'll help you.
Paige, really quickly, do you think when we put it on social, I'm so sorry, on social media, that maybe we can have still questions, and then maybe we can shoot them off to them and they can answer them, and we can put the answers in social media feed for anybody else that might have other questions that didn't get to come on tonight but can swap it tomorrow?
Yeah, absolutely. If you guys are both okay with that, I would love to shoot you guys some questions, do another go-to meeting with just the three of us and get those questions answered. That'd be great.
Sure. Our email address are on the BDC website.
Sure.
Feel free to shoot us an email and we'll be happy to help.
Perfect. We will go back to that. But yeah, so everyone have a great rest of your night. Enjoy the thunderstorms if you're close to them. And you will see this up on our social tomorrow. But any questions, feel free to email me. My email is paige@childrensdiabetesfoundation.org. Super long email, but I would love to answer any of your questions.
All right. Thanks, Dana. Thanks, Paige. And
thank you very much for everybody.
Thank you.
Thanks.
Great. Thank you. Have a good night.